Hi, I'm Eugene Zhang. I'm a PhD student in the Department of Biomedical Informatics at Vanderbilt University. Today, I'm going to talk about the research I've done, which is called Detecting Drug-Drug Interaction in COVID-19 Patients. First, I want to briefly introduce some background information about my research. It is well known that individuals who are older than 60 years or who have multiple illnesses are at high risk for having serious COVID-19 illness. Approximately 25% of COVID-19 patients have at least one comorbidity, and they are more likely to be using polypharmacy to treat their COVID-19 illness and comorbid conditions. So drugs may interact with others when they are taken together, and unexpected drug-drug interaction may lead to unexpected adverse drug events. So far, researches on DDIs in patients with COVID-19 can be broadly classified into two categories. The first category discovers DDIs by conducting researches based on public DDI datasets such as drug bank. But although there are multiple public DDI datasets that can be useful as gold standards, these public DDI databases cannot generalize well to unseen DDIs in patients with COVID-19, since they are not COVID-19 specific databases. The second category is DDIs based on clinical trials. However, it is challenging for clinical trial studies to select appropriate candidate drug pairs to study adverse events from a large number of drug pairs. To address these limitations, we use the post-marketing safety reports in the FDA Adverse Event Reporting System, also called FAERS. The FAERS database contains over 20 million reports, including more than 20,000 adverse reports related to COVID-19. So in this study, our aim is to identify novel interactions between drugs used for treating COVID-19 patients with comorbid illnesses using DDI detection models. This is the overall framework we use. We use the FAERS database to create COVID-19 cohort and define drug groups. Then we created 4x2 contingency tables and 7 detection models were used to detect potential DDIs in the FAERS database. At last, we evaluated our results by comparing them to the Liverpool database and random permutation results. First, I want to talk about the source data we used. We used the FAERS data, which is a database that collects spontaneous adverse events submitted by product manufacturer, clinician, pharmacists, and patients. In our work, we used 4 data files: demographic, drug, outcome, and indication data. Adverse events in the FAERS database are coded to terms in the major terminology, but drug names are not curated by the FDA, so we mapped drug names to RF known concepts by using the ETL process. Then we created COVID-19 cohort from the FAERS database in which each patient had at least one adverse event from January 2020 to March 2021, and the medication indication was for COVID-19 treatment. Then we defined drug groups. For drug groups, the first group includes all medication which were used to treat COVID-19 based on the FAERS database. And drugs that were used for the treatment of illnesses other than COVID-19 were included in the drug 2 group. And to determine the drug 1, drug 2 pairs, we only consider the drug pairs that appear in the same report, which means if patients are taking drug 1 and drug 2 at the same time, we consider this pair can have a chance to interact with each other. The next thing we have done is to identify DDIs using the DDI detection algorithm. First, we extracted all possible drug 1, drug 2 adverse event combinations and created the 4x2 contingency table. So reports are assigned to one of the cells of the contingency table according to the status of drug 1, drug 2, and adverse event. For example, G in the table indicates the number of reports that contain both drug 1 and drug 2 and contain the targeted AE. And H denotes the number of reports that contain both drug 1 and drug 2 and didn't contain the targeted AE. Then we use 7 most commonly used DDI detection methods. I will not go into details on these models. Basically, these models, except logistic regression, rely solely on the 4x2 contingency table we created. For example, the additive model detects DDI if the risk associated with drug 1 without drug 2 is lower than the risk associated with drug 1 and drug 2 together. Since no single method is considered as a gold standard, in our study, DDIs which meet all the criteria of all 7 models were considered significant. In order to evaluate whether our potential DDIs in patients with COVID-19 are previously known or novel, we constructed the gold standard dataset. We used the Liverpool database, which is created based on drug-drug interaction risk using results in clinical trials. The Liverpool database is COVID-19 specific database, which contains 2,089 DDI information. To test that the DDIs detected by the 7 methods are not random, we ran 100 random permutations by shuffling between drugs in the drug 1 group and drugs in the drug 2 group, and conducted a chi-square test for each permutation. This is the characteristic of COVID-19 cohort. About 29,000 reports met our defined criteria for COVID-19. Among the adverse event reports from patients in COVID-19, the female to male ratio was about 37 to 63. And the number of reports were highest in persons aged 60 to 79. The most frequent drug which was used for treatment of COVID-19 was aspirin. Here is the DDI detected by 7 models. Among the 7 models, most DDI signals were detected by the association root-mining model with 6,404 drug-drug pairs. In contrast, the logistic regression showed the most conservative DDI detection tendency, which has 3,705 drug-drug pairs. But it still had the highest number of drug-drug pairs confirmed by the Liverpool database. As I mentioned, we implemented the random permutation procedure, and the best random permutation result had 0 pair confirmed by the Liverpool database. This is a Venn diagram describing our result. There were 2,089 DDIs confirmed in the Liverpool database, while there were a total of 6,512 DDIs, which at least one of the 7 models detected in the FAERS database. The number of DDIs which all 7 models detected was 2,516. Among them, 49 pairs were significant in both the Liverpool database and 7 models. There were 2,467 pairs detected by the 7 models, but not found in the Liverpool database. For discussion, this study investigated potential DDIs in patients with COVID-19 by using 7 DDI detection models and employed the Liverpool database as our gold standard to discover potential DDIs which were unrecognized. Based on the result of random permutation, 2,516 DDIs detected by the 7 models are not likely occurring by chance. Thus, there is a high potentiality to generate clinical trial hypothesis based on 2,467 DDIs detected by the 7 models, but not found in the Liverpool database. There are several limitations in our research. Submission of a report does not mean that the information included in it has been medically confirmed. Also, there's no certainty that the reported event was due to the medication, since the FAERS data does include medical history, duration, and dosage information, which are important factors for DDI. In my last slide, I would like to thank the co-authors and my advisor, Professor Yu Chen. I would also like to thank the support of the National Library of Medicine for funding this study. Thank you very much for your attention.